I shot a pretty detailed video. It wasn't a video per se, it was an audio podcast last year. I'm trying to update some of those audio podcasts from the last few years into a video format. I think it's something a little more personal when you see my face talking, but also it gives you sort of an update in 2023 of how I approach things. I'll try to update some of these videos on a yearly basis, or sometimes more frequently, sometimes less frequently, depending on the topic. So this topic is female hair loss evaluation and therapy. I'm going to try to incorporate some of my concepts of surgery as well as medicine so that you have a very broad understanding of how I approach you if you're a female patient coming into me for hair restoration. So most of you probably know that I sort of divide hair loss into medicine and surgery. And there are some absolutely amazing benefits of medicine and some absolutely amazing benefits of surgery, and they don't overlap 100%. So I'm going to talk about broad sweeps and strokes of understanding of how I see each of these two components for women. This is very specific for women. If you're a guy listening to this and you're wanting a transplant, you're welcome to listen to it, but this is not applicable for you. This is really for women. So I want to talk about, for females, how I approach them differently than men, and this is really geared toward women. So a broad sweeping concept is that medical therapy is really good to manage hair shedding. It's good to slow down progressive hair loss. It's good to thicken hairs. It's good for global areas of problems. Whereas surgery is really good for a few things. It's good for patients with a more focal loss, like in the hairline or the hair part. It's not as good for trying to put hair everywhere. It is great if someone is very stable, so that person just needs a transplant. Unlike a guy where I'm worried about that hair loss progressing to complete baldness, women, if they've got a very long chronic hair loss and they've got a stable zone that's very discrete and we can design it, then surgery is a great option. Or an area that just doesn't have a lot of hair. Either they're born with a congenital high hairline, or there is an area that just is too thin and is very focal and it's long standing, then surgery can oftentimes be the best answer, even in lieu of even doing medicine. So those are some broad sweeping thoughts. Now I want to break down and have you understand how I address female hair loss when it comes to the medical side. So with men, when I see a man with hair loss, I usually just say, let's start some maybe finasteride minoxidil, get going on that, and especially if they're younger. Not always, and that's a very complicated discussion, but in general, I say with men, I need a biochemical blockade. What I mean by that is I need them to be on some kind of hormonal blockade of their hair loss, because it's such a powerful progressive hair loss in men, especially if they're on some kind of testosterone therapy. With women, what's very interesting is my first line is not biochemical for the vast majority of women, with some exceptions which I'll go into. But in general, I find that natural therapies are actually sometimes more potent for women and just simply easier to tolerate and more effective. So with women, I don't necessarily go to finasteride minoxidil as my first line. It's usually my backup. And that sounds weird, but I will tell you, I get such great results with natural therapies that I don't put it on my top list. So what are my natural therapies? So I talk about the big guns, the things that make big differences, because I can do a ton of things for women, but I'm more focused on things that will deliver really powerful results. So my most powerful therapy for women is hair stem. Hair stem is basically plant-based. I encourage you to listen to my video just on hair stem. I'm not going to go quite as into detail about it in this video, but suffice to say, it's one of the most powerful therapies I have and the fastest therapies in terms of female hair loss regeneration. So what hair stem is think about PRP, platelet-rich plasma. PRP is actually drawing blood and then injecting your scalp. But the problem with PRP is several problems. Number one is that it's very painful. Two is that the effectiveness is not that consistent. And three is the fact that you can have some hair shedding and recovery. And so these are all the reasons why I'm not a big fan of PRP anymore. And so hair stem is biomimetic, bioidentical, plant-based growth factors taken from a plant. And so if you are postmenopausal, you can think about how you may be on bioidentical hormones. In the past, in the 1990s, it was, conjugated equine hormones. Nowadays, it's plant-based, all natural. So this is wonderful. It's all natural. So I have a $25,000 machine that allows me to infuse these growth factors through the scalp with absolutely no pain and no recovery. And really very minimal to no risk of shedding. And much higher results with incredibly fast results. So oftentimes I'm starting to see results after the first session. It's a 90-minute treatment. It's done in my office. My staff does it, not me, but it's really pretty darn amazing. And after 3 rounds, I oftentimes see massive differences. So it's very, very, very powerful and very quick. It's much faster than minoxidil and finasteride, and it doesn't oftentimes put you through that shedding phase. I actually see results super fast. So that's hair stem is my go-to most powerful therapy out there. My other one, if it's hair shedding, if you came and just have hair shedding, my least expensive, easiest option is FoliFlow, a product. Yes, I developed it. Yes, I have a financial incentive, but then everything I'm telling you about it in a certain regard has a financial incentive. So disclosure-wise, I'm not on podium talking about my product, so I don't have to necessarily give you disclosure per se, but this product is incredibly effective. You can get on Amazon. I have it here in my office, FoliFlo. I have a shampoo conditioner coming out as well, probably this month. But the serum is so powerful. It shuts down shedding incredibly fast. So people with telogen effluvium, people with chronic shedding, it shuts it down sometimes in a day or two, and it usually within days to a week or two it's shut down. My au pair had all my Roombas were filled with her hair. She's 27 years old, healthy, just massive shedding, and she used it within a week. All my Roombas were dry. All her shedding had basically stopped, and her hair started to grow. It's nothing like I've seen with anything else. Can I guarantee it? Of course I cannot. But I am very proud of this product because of the speed and the safety. It's all plant-based growth factors as well. In terms of the actual growth, to grow hair like tremendous, it's not as powerful as hair stem. So if you're sort of shedding problem, FoliFlow is my go-to. If you are just thinning overall and shedding, I would say the hair stem. If you have shedding and growth, I would use both. Of course, the hair stem works on shedding and growth, and the FoliFlow works both on shedding and growth. But the FoliFlow is not as potent in terms of growth, and the hair stem is not as potent in terms of the shedding. And unfortunately, it's harder to maintain it with the hair stem. Hair stem is done once a month for 3 months, and then maintain every 6 months. With the FoliFlow, you just do a spray once a day. There's no weight on your hair. It's not like minoxidil. It takes you a second to do it. Very, very powerful. So that's sort of my philosophy. Other therapies such as supplements, Nutrafol, Viviscal, lasers, to me are far less potent. I would say the next layer is going to be my supplementation therapies, and then below that, in terms of natural, would be laser. Those are my 4 natural therapies, but that's the order of potency. Laser is far, far less effective, and the supplements are far, far less effective. But these 2 therapies, hair stem and FoliFlow, are my massive weapons in terms of improvement. I know you probably don't know most of this stuff because your doctor probably doesn't understand it, but I will tell you these therapies really, really work well. In terms of biochemical, as I said, most of the times I'm not using biochemicals as my first line for women, but biochemical does absolutely work in women. Finasteride, minoxidil. As you know, finasteride, also known as Propecia, is something that is not safe in women of childbearing age. If they understand there can be a teratogenic effect. Teratogenic display means a birth defect in a male fetus in the genitalia. They get a hypospadia underneath. It's a low incidence of this, but I will tell you, absolutely, if you are planning to have kids, absolutely no finasteride. Way too dangerous to do that. But if you're postmenopausal, they've actually done studies to show that finasteride can be quite effective. It's a higher dose than men, usually a 2.5 milligram oral dose or 5 milligram depending on the study. But what I try to do now is I do what's called the hair genome test. I'm not going to go into great detail with this, but I encourage you to watch my video on the hair genome test. But a lot of times, most doctors are not familiar with this. What they're doing essentially is just giving you a standard 1 milligram finasteride or 2.5 milligram finasteride, or they're giving you a topical therapy like a 0.25, or they're giving you a 5% minoxidil. Yes, those are very effective, but to me, I can tailor it to your genetic profile. It's a buccal swab. It gets me data back in 2 to 4 weeks, and I can actually tailor your oral or your topical dosing in a way that's very, very powerful. In general, I like the oral supplementation for a lot of reasons. It's a little less expensive. The compliance is much easier. The bioavailability is easier. It allows me to hit the whole head, whereas topical, you've got to place it exactly right. So a lot of people I've found on topical, they don't maintain it long term. Plus, there's an issue with applying it on the scalp, where you're going to not, if you're going to apply it over a certain zone, you may miss an area and may not be as effective. So I like the genomic test to get a better sense of what is going on in terms of exactly how to dose your topical or oral. Watch my video on Hair Coach so that you can understand this better, but the oral does have side effects. The finasteride has about a 1% sexual side effects. The minoxidil orally has about a 1% chance of lower blood pressure, heart palpitations, or swelling in the legs. If you've got a cardiac history, of obviously the oral may not be the right answer for you, maybe even not the topical. But in general, it's a very safe product, and I can titrate it and mix it for your exact genetic sensitivity and resistance levels. And what's interesting with this test is it also gives me exactly which vitamin deficiencies you're missing, so I don't necessarily even need to use Nutrafol per se. I can tailor it to exactly your genetic deficiencies and supplementation as well. So there's a lot of advantages for looking at a genomic profile and figuring how to dose you correctly. Does it overlap with the natural? If I'm taking the natural, do I need the other therapy? So there's a few ways to look at it. So first of all, the biochemical therapies take longer to see a difference, within 3, 6, 9 months to a year, whereas my natural therapies are very fast, within weeks to months. I will know to almost the maximal level that you need very fast. So for my patients that are really having serious problems, I can put them on both simultaneously, or I can at least get you on the genomic test, figure out what you're sensitive to on the biochemical side. If I'm thinking, God, this is a Ludwig 3, really bad donor hair, I don't have enough to do a transplant, I've really got to knock you out of the park with medical therapy, I may just start you on both very quickly to get you on going. Or if you want, some patients, if they're not as bad but they're sort of bad, I would do a genomic test, get them started on the natural therapy. Within 3 months, I have a very clear idea to what extent you're going to grow, because at 3 months, as I told you, your natural therapies have maxed out. It's super fast, in which case I could say at that point, hey, you know what, I'm still not quite happy. Let's go ahead and add the biochemical therapy. Since we have the genomic profile, we can easily just add that in. Now, it's going to take longer to see that difference, as I mentioned, and it can cause some temporary hair shedding. But that's a good way to look at. Oh, I forgot to mention also, as you probably know, with minoxidil, there's about a 15% chance of a secondary hair growth in the face. It's not due to getting it onto your skin. So the oral has a 15.3% chance of secondary hair growth in the face, and about a 5% of it's topical. So there is a chance of secondary hair growth. But what's interesting is the women that get that secondary hair growth, they get tremendously huge growth on their scalp. So it's not necessarily a bad thing, but it could be in your case. Obviously, if you're not liking it and you're saying this is not worth the penalty of the benefit that I'm getting from it. But in general, the biochemical is not my first line, but in people that are very severe or they're postmenopausal, I know there's some kind of hormonal issues, then I would say biochemical can be a great adjunct. Or if someone just says, look, hey, I just don't want the natural, or it's beyond my budget, I can't come in and do it, and maintenance only twice a year, it's very easy. If you said, hey, I want biochemical, it's what I'm used to, then if I said, look, I'm already doing great with a topical finasteride minoxidil combination, I don't want to stop that and lose the gains I've made, yeah, let's continue. But what I would do is then just tweak you, either convert you over to an oral or at least dose you with appropriate percentages that would be very sensitive to your own genomic profile. So that's basically how I manage female hair loss, but I always say that I'm treating the effect, not the cause. So in a way, I'm treating the cause. In other words, I am helping your biochemical profile in terms of getting growth factors to stimulate the growth. But in essence, the cause is hormonal imbalance or some other reason that may be there, and I don't know. So I always encourage my female patients to consider doing a test with the hormone levels. And so the ones that I always mention are DHEAS, dihydroepiandrosterone sulfate. It's a mouthful. It's the strongest androgen in females. It's good to know your testosterone, your estrogen, your estradiol, your estrione, all the different levels of your problems. Look, if you're a young female shedding hair, you need to check your iron levels. If you're having a lot of high menses, menstruation, you could have that problem. You could have hypothyroidism. If you're gaining weight easily, feeling sluggish, you could have a thyroid problem causing hair loss, especially if your eyebrows are having a problem. Plus, there's a ton of other conditions such as scarring hair losses that could cause it. That may be the problem. So, traction hair loss, where you have over-pulled hairs, that could be a cause. So there are a lot of treatments of that go beyond just treating female hair loss. This is a very broad category. What I've really talked about is sort of female androgenetic alopecia. In other words, it's female pattern hair loss, genetic hair loss. But I always encourage patients to look at the cause, which is get a hormone evaluation. If you haven't had a basic blood test, you should be doing it every year anyways. I just got my annual physical last week or 2 weeks ago. It's important to at least, and I get my blood test every month to 2 months or 3 months. I love checking my blood to make sure everything is on point. But for you guys, I have an easy ability to do it. I have it in my office. I can do it. For you guys, I would definitely say do a complete physical, get your blood test done, and get your hormone evaluations done. Now, here's the problem with hormones, is that allopathic doctors, in other words, people like me, medical doctors, after you've done your evaluation, you've only gotten so much that you can do. A lot of people don't do hormone replacement. They don't do that. And I'm not saying that's the right answer for you, but if you're postmenopausal, maybe it would be worth it after discussion with your doctor about whether hormone replacement therapy would be advisable for you. I'm not going to counsel you yay or nay, but I will tell you that that could be one of the reasons for your hair loss. And if you're not having your estrogens balanced, then it's something to consider. Then that's treating the cause, and again, I'm treating the effect. So other therapies such as Ayurvedic therapies, cupping, other things like that could help you. Ayurvedic medicine is a great example where if you understand that your gut health could be causing it, if your diet, exercise, if you're just, a lot of things, your body is off whack, it could be causing hair loss. I don't look into any of that stuff. Functional medicine is a great therapy to look at, other irregularities, mold exposure, toxin things. I'm not treating any of that. So I always say I treat the effect, not the cause, but it's good to look into all those things to make sure we're not missing anything. Is there a dermatologic condition? Do you have lupus? Do you have other issues causing the hair loss? And it's worth looking at that component as well. So that's a broad sweeping understanding. A summary again is that I prefer natural therapies, the kind that I've mentioned to you that work very, very effectively. If you've had failed PRP or failed Nutrafol, understand that what I'm offering you is far more potent than what you've had done. So I would recommend those therapies based on what I see for you. Of course, in a consultation, I'll be able to evaluate better. If you're having a lot of shedding, progressive loss, then surgery is not a good option. So let's talk and switch gears over to when is surgery a good option? When would that sometimes be the only answer? Maybe you don't even need medicine. So the things that as I mentioned, I'm going to reiterate some points. Redundancy is helpful to have you understand it. So if you're having a slow progressive hair loss, let's say it's over 10 years, that checks a box that says, hey, maybe surgery could be a good option because what if you're doing one surgery every 10 years rather than having to take medicine because you're not having a lot of shedding, you're not having a lot of progression, it's just slowly thinning. The second thing is that if it's isolated, if you said, look, I just don't like this area right here that's bothering me, or I just don't like my corners across here, or just this hair part really bothers me, surgery is so targeted, it works really, really well. If you said, I don't like this, that's difficult. Then it's very hard to take those grafts and concentrate them to get a good result. So I don't put them everywhere. So I call my transplants TLs, reverse Ls. That's talking about density issues. So what does that mean? Essentially what it means is the T is the central part and then the part in the center here. That T shape is how I design it. So if you like to part here in the middle, that's where I focus, or if it's on this part or this part, it's hard to hit everything. So it's much better to hit a central zone for maximal impact. I'm not going to talk to you about the nature of the procedure, the nature of the recovery, all those things. It's just way too much detail into this video. I'm just trying to give you concepts of how I address surgery medicine, and why if you walk in my office, I say, look, do not do surgery, let's do medicine. Or I may just say, just do surgery. Or I may say, hey, let's do medicine or surgery. I'll tailor it, but these are my philosophical underpinnings for how I address patients. So from a surgical perspective, by the way, if this is not clear, I do not do FUE in women. I think it's absolutely ludicrous to have to shave a head or put a patient down for 2 days trying to harvest one hair at a time. Even if you don't shave it and you do a window, you're going to lose density in one zone. No woman wants to lose density or shave their hair. Those are two major issues. So listen to my other videos on that. I'm not going to go into detail of why I don't shave the head for women and why I don't do FUE. I think it's just crazy. But I just want to talk about sort of aesthetic goals of when I do surgery, so you have that framework of understanding. So when I'm working on a patient, if it's like a frontal loss of thinning, surgery is the ticket. If it's too thin, medicine's not going to do much. And if they've just thinning over many years, or you've just thinning many years, surgery is such a great, easy option to manage that. Or if it's just this zone with a part, surgery is a great option. So if you've got slow burning loss without rapid shedding, you've got a very defined zone of loss that we got to manage. And the last part is a hard one, because I need to look at you to see this. Is your donor good? If you've got great donor hair, if you check off all those boxes, I may just offer you surgery in lieu of medicine, because surgery is going to be a better option for you. Those are the pertinent things to understand with female hair loss evaluation. I haven't really gone into detail the nature of the surgery, all those things. I haven't even gone into a deep dive on genomic, hair genome, hair stem. I encourage you to watch those videos, Hair Coach, how to be consistent with therapies. But these are broad, sweeping, philosophical strategies of how I manage a female patient.